Hello and welcome to this MRCP Pacers podcast for Pass Test. My name is Dr. James Galloway, and I'm going to share with you today some of the common pitfalls in the Pacers exam. And I think there's probably a very long list of these that people could put together, and I'm going to choose a select few. In fact, I've picked 4. The first one is not reading the instructions carefully. And this may seem like an obvious example, but actually, if I was going to set up a Pacers exam with the primary intention of catching people out, there is a very classic instruction that is misread. And that's in the cardiology station. I might write on the form, "This patient has been complaining of palpitations. Please examine." And perhaps the only clinical finding is that they have atrial fibrillation. Quite an easy case to pull up off the wards if you're struggling for cardiology stations in the exam. And I would be confident that almost half the candidates would present beautifully the cardiovascular system without mentioning that they were in atrial fibrillation. They would describe the pulse as being of normal volume, but fail to mention its regularity. They would even tell me the rate, but once again fail to mention that it was irregularly irregular. So always read the question. And in part of that it is important to remember what system you're examining. Not so much what system, but what station you're in. And by that I mean the muddle between communication skills and history stations. Because another common pitfall with regards to reading instructions is in a patient who you have to counsel about a new diagnosis of epilepsy in a communication skill station, where candidates start to go down the route of, is this really epilepsy, and what investigations have been done, and who confirmed the diagnosis? So it's important in those two stations to be clear about what you need to do in a communication skill station versus a history skill station. The second example was the panic station. For a lot of people this might be neurology, although that is slightly counterintuitive. If you've met many neurologists, I'm sure you'll be aware they're often quite simple individuals, and it's a simple specialty. But that said, there will be for many of you a single station that does engender fear. And that panic that you can engender about a particular station can build up, and quite commonly candidates will get in a rut. Take neurology, for example. The odds of chance tell you that the most likely station in a neurology case will be a peripheral neuropathy, and I would suspect most of you, even the ones that don't enjoy neurology, would be very competent at managing that. And that's an important mindset to have. To go into the station, it might be something difficult, but probably it is going to be a common or garden neurological condition, which you will need to present a nice examination and clear findings. The role of Pacers is not to be able to spot that someone has neurological sarcoid, or that they have some rare inherited disorder with an instance of 1 in 150,000 per head of population. So it's important to remember that the role of Pacers is to be able to be safe and competent at diagnosing common conditions. Speaking of common conditions, that brings me on to my third point. And that's missing the diagnosis of diabetes. In peripheral neuropathy, I hope you would all mention it. But actually, people often miss the key signs. The obvious ones being the BM stick by the bed, although they may not be apparent. But more importantly, it's the finger prick marks from where people check their glucose, people who are on insulin or other oral hypoglycemics. And spotting those can be the key to saying that this patient's, whatever it is, condition relates to diabetes. If it's an eye exam, the finger prick marks tell you this is almost certainly going to be either treated proliferative diabetic retinopathy or background retinopathy. The finger prick marks in a lower limb examination probably mean this is going to be a peripheral neuropathy. So always look out for the signs of diabetes. And my final tip is remember never offend the patient. And I don't mean go in there and obviously insult them, but it's often the little things. In the respiratory station, asking the patient to take deep breaths repeatedly for too long a period of time. I remember being taught by a respiratory physician once that never examine a patient for a respiratory exam with their legs hanging over the side of the bed, because he had once observed a candidate examining a patient in this position, and the patient hyperventilated and promptly passed out onto the floor. That's an extreme example, but always remember when you examine the respiratory system that if they're taking deep breaths repeatedly, they do get a little bit lightheaded. Equally in the cardiology station. When you're examining for murmurs of aortic regurgitation and you say take a deep breath in, breathe all the way out, and hold. I'm not going to go on, but you may actually, if you time yourself, find you're getting people to breath hold for quite a long period. And particularly in the example of people with cardiovascular disease, that can be quite unpleasant. Equally in the neurology station, be cautious about the over-enthusiastic percussion of tendons, and always be gentlest in the utmost when you're manipulating people to examine muscle tone. I think I'll leave it there. None of the things I've said are particularly shocking examples of what can go wrong, but I think sometimes having an insight into what the examiners see going wrong can help you remind yourself in the cases things to avoid. So all the very best of luck, and you might hear from me again in another podcast.